start please.
Good afternoon, everyone. So thank you for the opportunity. So I will be sharing the 7 top pearls for managing a GRT.
You said 10?
For the want of time, I am
अच्छा
cutting
अच्छा
it
अच्छा
to the
ठीक
7.
है
So mature and so.
GRT is when it involves more than 3 clock hours and the edges have the tendency to roll back. So first pearl is inducing the PVD. PVD is usually present in cases of GRT. It is absent if it is a case of a trauma or some vitreoretinal degenerations. So this is a case of closed funnel RD. You need to create a space by draining the fluid, removing the membranes, and putting a PFCL bubble. So it will help in creating the space and proceeding with your surgery. So next is the base excision. In cases of GRTs, the base excision should be done at high speed and low vacuum. Just remember to remove the base at the edge, the interior flap which is there in the GRTs, because it acts as a scaffold if you leave it. And after that, also remember to do the base excision in the opposite meridian, as it may act as a contracture and lead to the recurrence. So anterior flap management, usually it is a devitalized tissue and it acts as a scaffold for the anterior loop PVR. So you need to cut it down thoroughly with the cutter. You should not leave it behind. You should depress if you feel that it is coming in the way and you are not able to remove it. And remember to do the laser if some part of the interior flap is left behind. Now unfolding the retina. So this is a 360-degree GRT. In this you have to use the 2 instruments to unfold it, then put a PFCL bubble, and remember to put the PFCL bubble up to the edge so that the fluid is drained completely. In this case, this was a fold which was left behind even after the PFCL. So it can be unrolled by using the instrument, the closed instrument, so that it is unrolled. Now doing the laser part. So laser is to be done in 3 to 4 layers, especially at the end of the GRT, and never forget to do the laser at the end of the horns, because these are the major points from where the posterior edge slips out. So additional rows are to be given at the edge of the horns. And here we are also lasering the anterior edge of the flap. So the 6th pearl is prevention of the posterior slippage. It is avoided by not using the high and the broad buckles. PFCL is to be put at the edge of the GRT, and the SRF is to be removed meticulously by tapping it n number of times so that there should not be any pocket of the fluid. After putting the PFCL, you can do the fluid air exchange. Tap every edge of the GRT so that the fluid is removed, and then the laser is done. In this case, this was 360-degree GRT. So we are removing the fluid pocket from the every edge, every corner. And it is always not mandatory to that in cases of even 360-degree GRT that you need to do the PFCL and silicone oil exchange. Even with the fluid air exchange, you can manage the cases. And the last is, you need to tackle the concomitant pathologies like ERM. If there is a ERM, you can remove it under the PFCL. If there is a case of full thickness macular hole along with the GRTs, it should also be tackled simultaneously. It should not be left behind. The island peel should be done after removing the membranes. And if it is just kind of a PVR, just do, in this case, we converted it into a 360-degree retinectomy. It was a case of 180-degree, but with severe PVR, as the anterior membranes were not letting the retina to settle, so it was converted into 360-degree, then the PFCL was put, and the rest of the steps were done. So, thank you.
Thank you, Shilpi. Now we'll have you have shown videographically very nice pearls, and most of these are practiced by everybody. Anybody who does differently, Uh, this. So thank you, Shilpi, for your nice videos.